Welcome to the Life's Best Medicine podcast, where we are finding hope and healing one episode at a time. No appointment needed, no rubber gloves, and no coping. Just a healthy dose of life lessons to help equip you for this wild journey we call life. Hey everyone, this is a friendly reminder that we are here for entertainment purposes only. We may not even be that entertaining at times, but this is not medical advice. Talk to your doctor, check with your healthcare professionals before making any lifestyle changes or medicine changes. What we're talking about is our clinical experience and what we've seen. And so if you really want our advice, you can consult us. You can actually consult me as a doctor, or you can consult my guest and get all your questions answered. But we can't give free medical advice because we can't pay our bills with that, but we can help to educate you a bit and allow you to think a little bit. And always reach out to your medical professional before making any lifestyle changes. Thank you. Hey everyone, believe it or not, we are in November. Holy cow. It seems like this happens every year, and every year it just sneaks up on us. So this is the landmine time. This is where we try to just, maintain, not to go out of control. Thanksgiving, Christmas, all these things are coming up in the near future, family visiting and vacations and all that kind of stuff. So now's the time to really, really watch it. Use tools if you need to, like Health Code, who sponsors this podcast. They have great recipes online for pumpkin spice and, all kinds of things. You can make pudding or ice cream or things like that, because when everyone else is having their sweets, like it's really hard to stay strong. So look at those things. Go check out all their recipes. Health Code, Get Health, GETHLTH.com. We have a discount code with them, MedHealth, METHEALTH, for metabolic health. It's really important right now during the holidays as you enjoy family. Don't make it all about the food. Make it around the family and your connections, friends, spending time, all the important stuff. So allow them to help you with some tools. Also use your Keto Mojo, being able to track your ketones, see if you're staying on track your sugars, which are really important this time of year. And so I just want to thank them both, keto-mojo.com, for another year of sponsorship and keeping this podcast going. Also, I'll give a plug for myself, Arizona Metabolic Health, ArizonaMetabolicHealth.com. We can help you. We're doing consults. We're doing, short-term follow-up or follow-up forever. But I'm doing all online, so if you want to talk and get your metabolic health squared away, laboratories, things like that, please reach out to us at ArizonaMetabolicHealth.com. And thank you again for listening. And, stay the course during the holidays. You got this. Keep fighting on and stay well. Hello, and welcome back to the Life's Best Medicine podcast. I have a repeat offender here today, Dr. Paul Kolodzik from Ohio, and you're practicing in Florida and Indiana. You've got licenses in a bunch of places doing online stuff and in-house, but loved your book. It was super great to read. I think it's great information. I'll say it real quick. The Continuous Glucose Monitor Revolution. And I think that's what we are seeing. So Dr. Paul, welcome. Great to have you.
It's great to be back with you, Brian.
Yeah, thanks for joining me early it's early for me on West Coast. You're smart enough to be in the Midwest. One bone of contention, I just want to just throw it out there. I'm seeing this Notre Dame stuff behind you. You guys just kicked the heck out of the USC guys. So I knew it was going to happen this year. I looked at them like, these guys, their defense is so porous. It's going to be brutal. But Notre Dame's respectable. I mean, for a lot of years, I think they just put them on TV because they had the money. But they're legit team, and that was good stuff. So let's get that out of the way right up front. But Doc,
well, I appreciate your recognition of that. Yeah, we stumbled down in Louisville, but yeah, kind of made up for it last week. So,
yeah, that's good stuff. It's great. You have one downtime. They go, okay, we got to get together, and so hopefully you guys instigated that in USC because they got some tough games coming up. But hopefully there's some hope.
The USC Notre Dame rivalry that goes back probably 70 years now, I think is one of the greatest rivalries in college football. It's always fun.
No, what's funny? The greatest one of the greatest was the Bush push, right? Where they pushed him in. That game was ridiculous. And the funny thing is, I was actually speaking at a men's conference, And I came back and I'm like, oh, I can't wait to watch this thing. I knew what happened already because my phone was blowing up. And then I go to the recording ended right before that last, and I'm like, oh my gosh, you're gonna be kidding me. So I couldn't see the ending anyway, so I had to go like try to find it. But yeah, those are the glory days, the good old days, and all that kind of good stuff. So
I
good
was I
stuff.
was at that game. It was fun. It was
Oh
fun
my
until the
gosh, that
very
was
end.
ridiculous. Yeah. I have a lot of
And
Notre Dame friends that are enjoying their week this week. So that's why I
all
have more
right.
gray hairs. But anyways, but Doc, tell people about what you're doing. It's exciting, and you got a lot going on. So let's start with what inspired you to write the book.
Well, the value of CGMs is, so tremendous in terms of changing people's lives. And I don't know what your experience is. I know you use these regularly. But basically, the approach I take is slapping a CGM on a new patient and telling them not to change their diet for a week or 10 days. So they can just see where they live in terms of their blood glucose. And quite honestly, they can have a primary care doc talking to them for 7 years about, you got to control your blood glucose, you got to control your diet. This is going to cause problems for you down the road. And they don't have the visual. And then when they get this data on their phone and they see the spikes and they see the drops, it for some patients can be life changing. They finally get it and they understand what carbs and blood glucose are doing to their long-term health, and they change their lives. So, that was the initial motivation here. It's just like, the last chapter in the book is CGMs can change lives. And I firmly believe that. I quite honestly see it about weekly. So,
Yeah, there's no question about it. My practice is the most powerful tool I have, other than, connection with people, right? But
yeah.
when you see this and people can see it themselves and go, oh my gosh, and they'll tell me, look what happened on Wednesday. You know what I did? I thought, everyone tells me sourdough bread doesn't have sugar in it. Look what my sugars did, and all these things that rice, pasta, and they see it, then they go, ooh, I don't like that. And so I love it too from that standpoint of it. It's a lie detector test too, because we can. People say I didn't eat carbs all week. Well, what's this? What happened on Tuesday? Oh yeah, that's right. I went out for pizza. Oh yeah, I had ice cream that night. Oh, no. Well, you did have carbs then, right? So because it's easy because we all self-report. We forget stuff we did wrong, and then we under-report all the bad stuff. We over-report the good stuff a lot of times.
Absolutely. Yeah, so I use them diagnostically for a couple of weeks in a manner that we just talked about, just to see where people are. And then often use them therapeutically for at least a few months, sometimes longer, to help people guide their diet and kind of fine tune what affects their sugar and what doesn't. And, some people you put one on, using it to guide diet for a few months and they're good, they understand it, they come back to it intermittently. I've had patients, and I assume you have too, where, they put one of these on the back of their arm and they never want to live without it again. They kind of live by it. These are the people that are scanning, 45 times a day when they first get one.
Yeah, and it's amazing. Now we have the newer ones that you don't even have to scan it
Yeah.
anymore, and you could just go on with
Right.
your life and forget for a couple hours. Because most of us get so busy, it was like, oh, I forgot to scan it, and so you lose data after a while. So these will hold the data a lot longer, and I've been really impressed by what I've seen. And it's funny enough, and people will tell me this all the time. They go, oh, I was doing so great, and then my CGM fell off or ran out. My pharmacy didn't have it, and I went off plan for like 3 days until I got it back on because I they don't want to see it. Like even if
Yeah.
because you know what it's doing, you don't want to see it. So you're like, okay, I'm just going to be oblivious to this and put my head in the sand, because it is a valuable tool. And some people it's valuable because they don't want me to see what they're doing, but other ones are just saying, no, I'm competitive. I want to see my scores get better and better. I want my sugars to come down, and we perform miracles with these things.
Yeah, and the accountability piece is interesting because there are some people that they want that accountability. They want to know that somebody else is looking at the data. And you know how it is, Brian. It's like somebody spikes a little bit, a few days, you leave them alone. You don't bother them. They usually self-correct because they know what's going on and they know that you're going to be following their data as well. But if they're off the rails for 4 or 5 days, and then they get a call or a text from either me or one of my staff saying, hey, what's going on, can we help you, can we intervene? And I think it's truly helpful for people, for a subset of people, to have that accountability.
Yeah, and you have a background in addiction, so you can see it's the same thing as like when someone goes off the rails with alcohol or drugs, like then they go off the rails. But just think if we had something like this for that, for say, oh, you had to drink. What happened, Tom? And give someone a call and like, oh my gosh, hold on, they're aware of this. So, but with us, it's more the food addiction and how these addictions all kind of run together too.
Yeah, yeah, that's an interesting point. A continuous alcohol monitor would be very interesting. Yeah.
Yeah, I
So,
mean that would be for an accountability standpoint, that would be just something, right? Because you
yeah,
would see it right away. If AA had that, their success rate would go up like
yeah,
crazy because then their sponsor will call them and say, "Oh, I better reach out, or I'll drive over to their house right now. I see something going on." Obviously, we don't do that with low carb stuff, but it's one of those things where you're right, just reaching out, saying, "Hey, what's going on?" Oh, I'm having because we all know that the most likely thing for someone to binge and go off rails is when they're stressed, tense, life's not
yeah.
going great. So sometimes just having that support of someone saying, "Hey, we're in your corner. What can we do to help you?"
Yeah, you're right. It's just it's a mild intervention, and really, you're right. It's the emotional issues, the stress, and sometimes it's just having the ability to talk to. It's like mini cognitive behavioral therapy. What's going on? What can we do to get you back on track? And it works, I think, really well. So,
Yeah, and I think we have so
um,
many things in the pipeline that we could really help people, and maybe you and I can talk offline. Tro and I are kind of going to be teaming up a little bit more, looking at using his app to get people online to have conferences that we could have a talk in the Midwest, we could have a talk in the West, in the East, because right now he's been doing it all in the East Coast stuff, but for
yeah,
us guys working and stuff at 2:30 in the afternoon on Wednesday is not a good time. So things like that where we can really build a community where people from Ohio and Texas and Nevada and all these different states can kind of communicate together and help each other along the way.
yeah, Tro has been great with that, with really raising the ability to reach out to people and raising the profile really of metabolic health. So hats off to Tro on that. And yeah, if I can help in anything he's doing, that's something I want to be
Yeah, and I think
involved
that's what I'm excited about too. I think if we can say, "Hey, look, I don't want to take like Tro wants to take over the entire world. Like, I just want to be Arizona, California, maybe Nevada, a couple of states down here in my backyard." But yeah, it's really great. But we could all like when we have a cohesive message and we're helping people along the way. So, what have you learned, man? What are some big things you've learned over the last few years that you want to share with people
in.
about medicine or about
Um,
life or whatever?
Yeah. So the way I came about this, I think, my background was, in the emergency department. And it took me a long time really to understand that the major reason the majority of patients come to the emergency department is vascular and obesity issues. That's our bread and butter. It's, the overdoses and the traumas and the gunshot wounds that get all the press in the emergency department, but it's really the vascular issues, which is just like, what we see day in and day out, and coming to that realization and seeing, 80% of the patients be congestive heart failure or stroke or heart attack or peripheral neuropathy or peripheral vascular disease kind of moved me toward getting first interested and involved. And this is true of most of us. I think we first personally see that what a low carb approach can achieve, and then we think, well, well, I don't have to be part of mainstream medicine anymore. I don't have to be only reactive, or I don't have to be a doc in my office that's doing only disease management by tweaking hypertension and blood sugar medicine. We can be proactive, and we can go ahead and redirect the course of patients' health and their lives. And so that's what really motivated me. And I don't have to tell you, Brian, it's been so satisfying, to have a 21-year-old that's pre-diabetic that you turn a different direction and they're never going to go that way again. And we're having the 45-year-old that has high blood sugars, and quite honestly, just been told by their doc, oh, your blood sugars are a little bit high. We'll keep an eye on this. When during that pre-diabetes phase, I think lights and sirens should be going off, because that's
Absolutely.
when you can be pulled back from the edge. So
Absolutely. In the
it's
CGM, and again, going back to that, that's why we could see that and go, oh, look at that. After you eat, your sugars go crazy high, then boom, they tank and you get hungry again. Look, you get hungry at this point, right? And so you can
yeah.
see the physiologic effects. And you're 100%. I just want to jump in for a second and say that because so many doctors, so many patients I see now, their doctors will go, yeah, you're just pre diabetic. Don't worry about it. Once you get diabetes, then we'll manage it. It's like, Okay, that's like, okay, we see your oil, you have no oil in your car, but keep driving till you blow up your engine, then we'll fix your engine. It's like,
That's a great
okay, I don't want
analogy.
to use my mechanic.
That's a great analogy. You're right. It's like those are the people that it's so important to intervene. And I mean, the reason I think you're doing this as well is because you don't want to be, you decided you didn't want to be relegated to that model where you have 20 minutes for a patient and all their blood sugar comes back high, and you really don't have time to intervene in the way you want to intervene to change their direction. Modern medicine, it was different, Brian, and I'm maybe a little bit older than you, but when I got out of school, it was still docs in their own practices or small group practices. And, I worked in some rural areas where, there were some of these primary care docs that were just pillars of their community in their own small practice or group practice. And, they would deliver babies and sometimes then care for that same individual 60 years later when they were having health problems and dying. I mean, it was, the
And
way they were integrated into the lives of their patients
they knew their
was,
patients, right? They knew their
it,
patients. And I don't know if you ever watched Dope Sick with Michael Keaton. It's worth watching that because you see this guy was a family old school doc. He wanted to help people. Then he got tied into this whole opiate epidemic crisis, and you realize, man, it's hard because then they knew people. Like if you look at these big systems here, like I talk to people all the time. They go, I never saw the same doctor twice. I would see someone else every time. I go to urgent care. They like no one really was invested in that patient or knew them. I go, oh, Tom's going through a divorce. We better keep a closer eye on him right now, or whatever it is. These
yeah,
these social
yeah.
aspects.
Yeah, so which are so critical. And with most docs, most primary care docs in particular, now working for health systems or, large, sometimes publicly traded groups, we just have lost something there. So to have, this alternative where I can spend, an hour with patients if I need to, and really get to the bottom of their issues, have them understand metabolic syndrome, have them understand the physiology of carbohydrates and blood glucose and insulin, and have them really have a deep understanding as to why they need to follow, a low carb intermittent fasting strength training program is very satisfying because the success rate is, I mean, Brian, I mean, I have a few patients that fall out and don't progress, but 95% of them using these tools, which is basically, CGMs and time in my office, where I'm able to explore with them their issues and then help solve the problems, it is very successful, high rate of success.
Yeah, and I think that's so important that you bring that topic up is the biggest regrets we have are the ones we can't help, the ones who fall out of the program, the ones who this addiction is so strong, or these issues you have are so strong. And that's one thing I've been real this last year I've really focused on looking at the mental health issues of it. There's this ACE questionnaire that I always thought, okay, stuff happened when you're a kid, but now you start looking at the ramifications on the big scale and go, oh my gosh, because if this person's bitter at the world and angry and stressed and has no self-esteem, it's going to be hard to fix that. Just you can't just. That's why I changed. I don't know if you know this, but I changed my company from low carb MD San Diego to San Diego Metabolic Health and Arizona Metabolic Health because it's
Yeah,
really about the whole picture of metabolic health. You can't just change one of these five variables that Ben Bickman talks about and think you're going to get healthy. Like, oh, I'll just eat healthy, but I'll smoke crack all night and I'll not sleep and I'll be out, you know, not exercising and sit on my couch all day. It's people have this perception, but you have to say we got to get our lives in order. It's really about the Mediterranean lifestyle, not just the diet itself.
absolutely, absolutely. It's multifaceted, and when we can help people understand, some of those pillars and how you get there and acknowledge their underlying stresses or work situation or family situation. Again, I feel like we're kind of replicating the, the way medicine was in the 50s and the 60s and the early 70s. And back then we didn't have the tools that we have now from a technological or pharmacological standpoint. But we had other tools, which was that connection, that greater connection with people that helped solve those issues.
Yeah, and what's funny is the revolutionaries are going back to what they used to like. These guys were so far ahead of us in the 1800s and 1900s in so many ways. So many ways, obviously, they didn't have the tools we have now. They didn't have CGMs. They didn't have Yep, but they didn't really need it back then. But they didn't have antibiotics. They were just kind of like making observations, and all these, they weren't looking at randomized controlled trials back then. Where they were looking at paid by pharma. They were looking at, okay, how's my patient responding? Let's tweak this and see what happens. And they would say, oh, whatever Paul's doing over there in Ohio is working. Why don't we replicate what he's doing and see what happens in our clinic in North Carolina or whatever, right?
Yeah, and quite honestly, that's kind of what we're doing in our metabolic doc community today, I think. I think we're keeping an eye on each other, interacting, communicating, and Brian does something that works, then I'm going to go ahead and kind of replicate that. And quite honestly, that's one of the things I wanted to do with the book on CGMs, because it's still, I mean, as you know, I mean, it's still a very small minority of docs that are using these devices in non-diabetics. And there is sometimes even a little bit of backlash. Sometimes diabetics can't even get hold of these devices in terms of insurance coverage. And people sometimes think, well, these devices are made for diabetics and measuring insulin doses. But gradually there are more and more people understanding the utility of these devices, using them in the manner that we've talked about diagnostically and therapeutically. So I think the ball is rolling down the track in terms of increased recognition of the value of these devices. And I just think we keep proselytizing and getting the word out, and more people will get on board, and we can change more and more lives.
Well, I think that's the biggest thing too, is I've heard it said multiple times, everyone should have one of these. Here's the problem. This typical doctor out there in the system says, oh my gosh, every day at 2 and at 5 o'clock, your sugars go crazy. Let's throw a drug at you at those times instead of saying, what are you doing at those times that we can, right? So we can correct that. Or if someone like you is a huge workout guy, like if I sprint and go work out really hard, which I'm hoping to do this afternoon, my sugars go crazy high when I'm working out like crazy. Does that mean,
Yeah.
okay, exercise is bad for you because your sugars, you have to understand what the data is saying. And I think that's what's happening. A lot of doctors don't know what to do with the data. They're not checking insulin because they don't know what it means, right? So
But it's also,
yeah,
don't
go
you
ahead.
think it's that they're so overworked and overburdened that they really don't have the time to implement and manage another device? I mean, for non-diabetics or people that are not on insulin, it's just another task they have to address, and I think that inhibits the spread of the use of these devices despite their value.
Having to learn something new, and that's what's frustrating. I've had patients come over from a big HMO in town that they see me for this part of their medicine, right? If they get hit by a truck, they go over there. But it's amazing, and I had people with, I mean, you see the results and you go, oh my god, this is. I have a lady, she lost 58 pounds, came off all of her meds, came off her blood pressure medicines, her heartburn went away, her mood, all this stuff that we see routinely in practice now. She goes back to her doctor over this big system, and they never said a word about it. They go, okay, we'll just take it off your med list. Like, not like, you lost 58 pounds. Do you have cancer? What happened? Like, what are you doing? And so ultimately, I talked to one of the head doctors over there at this program. I say, look, I could help you guys. I'll just I'll come give a free talk. And they're like,
Yeah,
we're not interested because what would they have 8 minutes per patient? You think you can go through this? Their system does not fit this model of
right.
prevention. They can't do it. They don't have time. What do you want us to do? Sit there. We have 8 minutes. We're going to talk about what happened when you were 9. You
Yeah.
see what I'm saying? Like they don't see that, but that's what's giving them all these things that they have. We got to get to the root cause at some point.
Yeah, absolutely. So, I mean, it's a style of practice that I very much enjoy. And after, getting my butt kicked in the emergency department for years, now being able to just sit down, see six or seven, I don't know how many people sometimes I have very low volume days. I'll see 6 or 7 patients in a day, and I'll get to spend an hour with each one, and we put plans together. So again, very satisfying.
And you can see that when they come back, it's like the same thing. People will ask me, like, how do you spend so much time with me? It's like, because you know what? You won't need my time in a year. You won't need me this much. And it's an upfront investment for me. I'm investing in you, right? I want you to get on track, and I don't want you to have to see me every week. And guess what? I make more money if I don't have to see you every week, right? It's easier for me. My life gets better. I can go to the beach on the afternoon if I want to and go for a walk.
Yeah, fix the problem. Hey, so we talked a little bit before. I don't know if you want to, let's do this. Let's talk a little bit about the semaglutide issue.
Yeah, let's
Is
do
that
that.
okay?
Yeah, I think
Yeah,
people know my
because
stance on it for the most part, but yeah, for people who don't know, this is the Ozempic and Manjaros of the world, and I think it's a good topic that we should definitely touch on and give our opinions on. I think we may have a little difference of opinion, but I don't think we do. We talked a little bit. I think we're united in that. So tell
Yeah,
us your opinion on that, Doc, since you brought it up.
well, you and I talked about the way I think we both use this, which is very, very judiciously, very, very low doses, very limited periods of time. And this is my perspective on this, Brian, and your listeners, is that unfortunately there is a mania out there right now related to these medications. And the way I look at this, and I don't know if you agree or not, but if I can use these medicines appropriately at very low doses for limited periods of time with an intent to get people off it, it's the Stephen Covey thing. It's like begin with the end in mind, and the end in mind is that you're going to be off this medicine in 4 or 5 months. Um, then I think that's a better alternative than somebody just getting on the internet and finding a provider that'll do a 15-minute visit with them and then work with them to crank them up to maximal doses indefinitely. So my perspective on this is that the genie is kind of out of the bottle on this, and it's not going back in. I think these medications are going to become maybe the most prescribed medications in the history of the world at some point. I think that possibility exists. And so I feel that if I can bring people in and focus on the lifestyle changes, which we talked about, low carb, intermittent fasting, strength training, which is, we'll get maybe to this, very, very critical if using these medicines at all. Then I can help them use the medicines correctly and get them off the medicine as opposed to them going somewhere else and being committed to medication use for the rest of their life.
Yeah, I think that's I think it's a clinical and it's an individual base. That's how I look at everything and go, look, here's how I look at it. I think in medicine we've done people a disservice. I don't think you and I maybe have, but I think in the standard practice, for instance, I have a guy who had full blown diabetes, out of control. Uh, wouldn't change his diet. He ate horrific stuff, and every week, and I love the guy, and I go, look, man, you're a disaster waiting to happen. I'm telling you. But he goes to his endocrinologist, goes, I'll tell Dr. Linsky to screw off with all that stuff. Here, I'll just give you more insulin. This guy was on U500, super concentrated insulin. He turned into a horror show of what could go wrong with modern medicine, and every week I was like begging him, please, I'm telling you, you got to give up your soda and your orange juice and your chips and your crackers and all that stuff. And he wouldn't do it. He goes, my endocrinologist says I'm fine. I'm like, okay, I'm not gonna argue with you, but I'm telling you, this is what's coming. Here's what's coming. And I said, at some point, you're gonna choose those foods and drinks and all that over walking. Are you willing to do that? If you are, that's your choice. And then guess what? He had a stroke, he had all these problems, and it turned into this horror show. And he came in, he goes, doctor, don't say it. And I go, what? I said, no, I wouldn't say it. I know he knows what I'm saying, what I've been saying
Yeah.
all along. And I've showed him my other patients and all that. But that guy went home that day, poured out all the soda, dumped everything in the garbage. And, he all of a sudden he starts getting better. He lost 58 pounds in a few months and he started feeling good. And he was able to go play basketball again and do things again. And you go, you know what? So I think the point is, in medicine, what we've done is like, okay, here's what I'll do. I'm protecting myself as a doctor. I'm going to put you on a statin drug and you can eat whatever you want now. I think that's malpractice. And I think it's just as much malpractice to do a bariatric surgery on someone and never change their mind, their mindset, their relationship with food, their addiction. It's an addiction when you get to be 500 pounds.
Yeah.
Most people before that would say, oh, I got to do something. But you have to say, what's the relationship like? This is what I'm talking about, this big picture that you and I are both talking about. So you can't just say, I'm going to throw a drug at you and you're going to be great. So, yes, I agree. If someone has major food addiction, they're hungry all the time, but guess what? Most people, when they're hungry all the time, you're going to look at their insulin, it's going to be 58 or 62 or something like that. They're not going to have a
Right.
normal insulin level when they're eating like this. So it's that combination of things. My concerns with the drug is this. Instead of making muscle, these precursor cells start making the progenitor cells are going to make fat cells. You're going to have way more fat cells over time. What happens, you get, instead of having 10 fat cells, now you have 300 fat cells, and they're going to fill up when you stop the drug. So at some point you're going to, like what you're talking about, lifestyle, you're going to have to exercise, cut your carb intake, and do all these things. You might as well do those now while you go on the drug if it helps you get on track, right?
Well,
So
but
yeah, absolutely.
before you go on the drug, so the way I use it is you got to do these things first before we're going to talk about that.
That's great. I think that's the way you do. You go, let's demonstrate, just like anything. people don't realize this, and you know it because you've been in medicine. You can't just walk in and, oh, you can if you're paying cash. But if you're going through your insurance, they're going to say, okay, you want to do a bariatric surgery? Okay, you're going to have to go see a psychiatrist. You have to go here. You have to do all this crazy stuff. So it's a year down the road. So like in a year, how much weight could we lose just doing low carb and cutting your, doing some exercise and moving and, working on yourself? And a lot of people, once they do the low carb for a while, they go, I'm not getting surgery. I already lost 100 pounds. Okay, I can do this now. So it's
Yeah.
that. I agree. It's really figuring out that person in front of us and getting the mindset, because everyone thinks bariatric surgery, oh, you just go do the surgery and you lose weight and everything's great. No, there's a lot of cost to that. There's a lot of downside. And the same thing comes with these drugs. There's no, like you said, there's no genie. Like the genie's going to give you a couple of your wishes, but it's going to give you a lot of wishes that you don't want.
Right. Yeah. Absolutely. So let's talk specifics. This is the way I use these. So people come in, we go through the whole diagnostic phase first, and then we talk about it. Basically, it's a plan of what are the carb targets, what are the protein targets, what's the intermittent fasting goals, what are the activity goals, and of course, I tell them to get off the elliptical machine and get into the weight room. Not, I don't mean completely ignore cardiovascular, but you need to be
But
spending
focusing on muscle
3 quarters
mass, no question about
of
it. Metabolically, that's
yeah.
going to make us the most healthy. Yeah.
Yeah. I mean, soak up more insulin, soak up more blood glucose, et cetera. So, if you put these changes in place, and then let's say you're, 4, 5, 6 months down the road and you stall, as a lot of patients will stall. And if we're having trouble working through that with some of the tweaks related to those components, and they request to go there, I don't offer it, but they request to go there, then we start talking about like super low doses of semaglutide, and I see good appetite suppression with low doses. So the normal dose of Wegovy goes up to 2.4 milligrams weekly. I've got, quite honestly, a majority of my patients under a milligram and never go higher. I mean a majority of my overall patients. I mean a majority of the patients that are
Who
on
do it?
semaglutide.
Yeah. The select few that you do it with. Yeah, exactly.
Right. So I maybe got 10% using it to begin with, and then many of those patients are on zero point 0.5 milligrams. And again, we talk about begin with the end in mind. As a clinician, I don't feel good about starting this medicine on you and committing you to a lifetime of treatment with it. So let's talk right from the beginning about, the length of time you're going to be on it, the low dosages we're going to use, how we're going to titrate it up very slowly, try and titrate it back down rapidly, and how you're going to have to be doing these other things to avoid the weight regain that occurs when you come off, and the muscle mass issue, and how, it's like, if you aren't going to be willing to strength train, then we aren't doing this.
I agree
Because
100%. Yeah, because the data is showing that 40% of the weight loss is muscle mass. You lose muscle mass, it's like when you go on a starvation diet, you lose muscle. If you go back to eating less than you were before, you'll gain more weight than you started with.
yeah,
So that's the
yeah,
problem. And I agree with you 100%. You do weight bearing exercise, activity exercise. The problem is people think it's the magic genie. I'm just going to shoot this and I'm not changing anything I'm doing. And that's a total
yeah,
disaster waiting to happen.
yeah. So the philosophy, whether it's right or wrong for me, is let me keep them out of that mainstream approach of just taking a shot. And if in a few people I got to use this medicine judiciously to help them reach their goals, then I am happy to do that. So,
Yeah, and I think
and
also if someone has hyperglycemia that we're trying to keep them from going on insulin, you do everything you can to prevent that.
right,
So sometimes
yeah,
an indication for which it was originally for, is saying, hey, let's try that for a little while so we can get your sugars under control, get your weight down a little bit. But
right,
like you're saying, you cannot. It's the same thing. I have people with the same mindset. A guy I was just talking to, he wanted me to put him on high dose testosterone. I was like, dude, you don't work out, you smoke, you stay up all night, you're not taking care of yourself. And I go, do you think just shooting testosterone is going to put muscle mass and make you feel like a 22-year-old? You got to change your lifestyle. And he said,
yeah.
oh, maybe that's why when I took steroids, it didn't do anything. Yeah, you got to go to the gym and work out. Even if you're doing steroids, you can't just, these guys aren't just shooting steroids and get to be like, Sean Baker. Ain't going to happen.
Yeah, yeah,
You got to put the work in. Plus, from a heart standpoint, not only that, exercise from the standpoint of mental health, stress reduction, dealing with life, feeling better, being more productive, mental clarity. I mean, I have a slide I do, and at the beginning of the slide, it said, exercise is useless, except if you care about these things. It goes all these things sexual. There's like 2 pages of stuff that exercise has been shown to help clinically, and you go, okay, maybe we got to look at that.
Yeah. Yeah.
And being in
So
Ohio,
I
that's
mean,
a challenge, man, because I know what people eat in Ohio, and that's a
yeah,
disaster show.
we got plenty of prospective patients in Ohio. Yeah, there's a lot of people that need these services, and quite honestly, after years now, it's great. I'm now developing relationships, which I'm sure you have as well, with primary care docs, OB-GYN docs that are looking over, because I'm the only one that I know in Southwest Ohio really that has taken this approach. Really, not a lot of metabolic health practitioners in the Midwest, and so you have some success, and now the OB-GYNs and the internists and the primary care docs are seeing some success that I've had with their patients, and quite honestly, they may have struggled with for years, not because they didn't put the work in, but because the patient just never could understand really the appropriate approach to getting to metabolic health success. So now I'm getting more and more referrals from other docs, which of course is very satisfying. And medicine changes slowly, but even those docs, even a lot of the primary care docs and the OB-GYN docs are beginning to understand the value of this, metabolic health, low carb, intermittent fasting, strength training lifestyle.
Yeah, it's hilarious because one of the old docs that was with the old HMO I used to work with, who thought I was nuts when I started talking about low carb, even though he saw me take 11 people off insulin in 6 months. And he said I was hurting the system because if those people are on diabetic or get the diabetic ramifications, then we get less money from the government. But that's besides the point. Right.
Well,
But
I don't
he
know
said,
what to
"Hey, are you
say
going
to
to
that.
Boca this year?" I was like, "What? Like, you're going to a low carb?" He goes, "Yeah, one of my friends told me about it." I'm like, "Oh my gosh, man!" I go, "Finally, you're jumping on board." Like, you see, because like I just want to step back. People don't realize like the devastation of being a doctor and watching your patient fall apart in front of you, seeing amputations happening, you see leg ulcers that won't heal. People can't appreciate what we've seen. What you've seen in the ER, I know what it is because I've been there. It's horrific what you see. You go, oh my gosh, if they would have managed this guy 10 years ago, he wouldn't be here with me right now. But people don't realize that because we have even though they say we focus on preventive medicine, we don't, for sure not, because we're not getting to the root cause ever. Most of the stuff we're treating are the symptoms and not the actual disease itself.
See, I mean, it sounds like a little bit of a time you're changing the thinking of people down there in Southern California.
Not only that, I
Um,
just got a referral from a doctor and from a patient. I'm talking to him. I'm like, hey, how'd you find me, by the way? He said, my cardiologist sent me to you. I'm like, oh my gosh, this might be a first. I can't believe that. His cardiologist knows metabolic health. And I go, how's your cardiologist know? Oh, he lost 58 pounds doing low carb. I was like, okay. Right.
yeah,
They have to have
well,
personal experience with it. If not, they think it's the craziest thing on earth.
yeah, yeah. So things are changing slowly. People like Phil Ovadia, that opens up chests and does bypasses for a living. Now through personal experience and with his patients, knows the
Yeah, I just
value
interviewed
of this
Lily
approach.
Johnson. She's a vascular surgeon, low carb keto, and so you start realizing these people don't want to do surgery on everyone. They want to prevent it.
Yeah. It's a movement, Brian. I mean, I'm just so thrilled to be part of this. It's going to take years. Medicine changes at a glacial pace. It will take years and years, but we will get there in terms of people understanding the value of this approach to living. Despite swimming upstream with the food processing industry and the medical
Conflict of
pharmaceutical
interest.
industry and health
Yeah.
systems. We are swimming upstream, but you can't deny the value of the truth. And when people's lives change, other people notice that. And so we're making progress slowly but surely, and I'm actually thrilled to be a part of it.
Yeah. And I think the more we're around, the more we start realizing there's more of us out there than we think. When we were isolated, Tro and I, when we started the podcast, the low carb MD podcast, we were just lone wolves in the forest, and it's going, what the heck are we doing here? But we were at the same time we were watching Fetke and Noakes go through their trials. I'm like, oh geez, do I really want
Right.
to go here? But it's just amazing that this was my first clue to say, I've had other clues, but this one when I said So Fetke's telling people not to eat sugary cereal for breakfast, and everyone's going after him. He goes to trial for 3 years for saying don't eat sugar for breakfast. Like it's incredible. I mean, and he has data, and Professor Noak's the same thing. He's like, hey, look, I got diabetes. I run. You're not going to outrun your bad diet. And he goes, look, that's what I thought. And he was the biggest proponent of carb loading. So when you see someone like that, you go, okay, let's step back and see, do we change course? Right? It's
Absolutely.
incredible.
Yeah, it's incredible, and it's fun to be a part of that. Can I mention one more thing about the
No,
semaglutide, which is
yes, you
interesting?
can. I'm kidding, of course.
Yeah,
Yes, stop.
given my so you
This is
know
your
you and I talked a
platform.
little bit. What's that? I'm sorry.
This is your platform, man. You whatever you want to talk
Oh,
about, I'm all ears.
I am your guest. So, but let's go to another area a little bit, which is the addiction area. As you know, here in the Midwest, Southwest Ohio has been the hotbed for the opiate crisis. And so I did some addiction medicine, primarily using Suboxone and naltrexone, and then that kind of evolved in to using some naltrexone for alcohol. So I'm talking about the alcohol component of this a little bit. Naltrexone is an opiate blocker, and there's a method called the Sinclair method. We've talked about this before, where if you take naltrexone before you consume alcohol, you get a little bit of a less fuzzy and warm response from the alcohol, and over time, you're able to achieve harm reduction. So this is a different approach. It is to decrease alcohol use initially rather than having the only way to manage excessive alcohol use be abstinence. So I don't believe life is either black or white. I believe there's a lot of gray areas in between. So this is an approach to help patients decrease alcohol use. And then if they want to stay at decreased use successfully, I can support that as long as it's not excessive. If they then want to move on to abstinence, I really, really support that. But basically, it's a you need to walk before you run, and naltrexone, not a perfect tool for this, is a helpful tool for this. So I'm kind of saying that as an introduction, which I'm going to ask you a question as to what you see. Again, back related to semaglutide. I have not used semaglutide specifically for alcohol use, but I will tell you, I have many patients that come back to me after using semaglutide, Wegovy, Ozempic, and saying that really they have much less desire for alcohol, or that their alcohol use has gone down. So I'm interested in your thoughts and your experience on that.
Yeah, I'll tell you, this is the funny. It is actually funny you're saying this because while you're talking, I'm thinking. I always think of mechanism. Like, why would that be? Why are we seeing what we're seeing? And so early on, if people are interested, go back to episode number 10 and 13 of Low Carb MD. Right at the beginning, we're over 300 episodes to give you an idea how early on that was. And we talked about this. I said, this is Tro and I both said, look, it's weird. People are coming in, they're doing low carb keto, and they're like, I don't crave alcohol anymore. I quit drugs. I'm not looking at pornography anymore. It's like, what is
Yeah,
that? So then we started
yeah,
reaching out to addiction experts. So you go, because while you're talking about low dose naltrexone or naltrexone for alcohol abuse, I'm like, okay, how many people have alcohol and sugar addiction? So whenever they drink, they want to eat crappy food, right? Happy
yeah.
hour, like people are doing great. They go to happy hour, have a couple of drinks, and I watch the continuous glucose monitor, and I could see the progression of what happens because you're like, screw it, we'll start tomorrow, honey. Let's go have fun, and we're drinking tonight. We're gonna go out and have French fries and Coke and what all that, whatever. So yeah, I'm very intrigued by this, and I don't know, and I think with the data we're getting back from Chris Palmer showing you decrease inflammation in the
Right.
brain, you decrease
Yeah,
these insults that people's bipolar gets better, schizophrenia gets better, all this depression, anxiety, stress. We know for a fact that poorly controlled diabetics have major depression. They're at massive risk for depression, but the depression came second. First came high sugars, high. So what I'm
yeah,
thinking is what we're seeing is the benefit of these drugs is you're lowering the sugar level down, you're lowering the inflammation down. And if
yeah.
that's true, and naltrexone is playing a role in that. So for me, I'm extrapolating a little bit from what you're saying and saying, okay, if I have someone with a severe candy addiction, why are we addicted to candy? Because we get stressed out and we go, okay, I want to have that sugar. When you take that first insulin spike, it increases serotonin, dopamine, all these feel good
Dopamine
chemicals in your
response.
brain,
Yeah,
right?
yeah.
So would low dose naltrexone have a benefit in people with severe food addiction? I would be really intrigued to see that. I don't know that I haven't looked at the data to see if there's data, but if it's working with alcohol, and there's no reason that to believe that a low dose wouldn't help block some of that feel good. So all you get the negative connotation of eating candy. At some point, you go, okay, this isn't fun anymore.
Yeah, yeah. So I see that in the Sinclair method patients. Even though previously that was part of my addiction practice, they lose weight. Yeah, I haven't actually specifically slapped a lot of CGMs on those patients, but they lose weight. So what's the reason for that? Is the reason for that is that they're getting an inhibited dopamine response to food as well, in addition to alcohol? Or is it just because they're drinking fewer? No, I'm not a calories in, calories out
Ooh,
person, but
yeah,
obviously,
but that plays a role. If you quit drinking, you lose. Like if I have wine on the weekends, I gain weight every time. If I don't
yeah,
drink, I don't gain weight. So you go,
yeah,
okay, there's something to that big. It screws up the metabolic rate, especially someone who's strict low carb keto. It does have there's ramifications, right?
yeah,
I have a family member who got diabetes at 158 pounds, but he was drinking a bottle of wine every night. So sure,
yeah.
there's sugar in that, but really what it does is screws up the metabolic, the whole system, right? Plus, alcohol screws up sleep cycle. So when you're not drinking, your sleep gets better and you get a more sound sleep. That helps the metabolic rate. There's
Cortisol is
studies on all this stuff, and we just haven't pieced it together yet, right?
right, right. I agree, but without knowing all the mechanisms, knowing the approach, I think can be helpful in terms of let's just get the blood sugar down. Maybe, as Chris Palmer advocates, let's get you in a little bit of ketosis, which I know you live in ketosis most of the time, right?
Yeah, I'm
Personally.
low dose ketosis generally just now because
Yeah,
I've been in it for so. But yeah, you go in and out of it. You're gonna go through life. You're
that's what
gonna
I
have
do.
whatever. Sometimes you have some mango or something. But it's not that that's the goal. It's saying, okay, look, how do I make myself as metabolic? I think the goal is not necessarily ketosis, but keeping your insulin under control, and that has to do with stress and sleep and all these other things. So what you're doing is really, if someone's struggling with alcohol and you get them off alcohol, guess what? Everything else gets better
Yeah,
in
yeah, yeah,
time. Initially,
absolutely.
like their blood pressure goes crazy and it's stressful and you miss your best friend and all that. But with time, people have a mental clarity and they're like, oh my gosh, I should have done this years ago. Like it's such an amazing thing. And you think about it from another mechanistic standpoint. I remember years ago before I understood low carb and met Jason Fung and all this stuff. I saw this study about metformin being used for fibromyalgia, and I was like, that is the dumbest thing on earth. That you're using a diabetes drug to help fibromyalgia and people are improving. Guess what? Metformin lowers insulin levels, lowers sugars levels, right? And people feel better. Well, maybe it's helping with the depression that's always, I mean, not always, but a vast majority of the time part of fibromyalgia.
Yeah,
Maybe that, like in retrospect, I go, that study makes sense now. And then with anti-inflammatories helping depression, Celebrex, there were studies showing that people on Celebrex did better from a mood sample. What? Decreased inflammation in your brain. So now
yeah,
we're introducing all these things that cause inflammation, like alcohol being one of them. And you go,
yeah.
if I'm depressed and I drink more, then I get more depressed, and then I have to drink more because I'm. See what I mean? We get into that cycle, and then you don't sleep, and then everything's screwed up.
Right. So, multiple tools in the toolbox in terms of, low carb, ketosis, maybe naltrexone, and then, semaglutide, maybe just by lowering blood sugar can be part of that as well. But I see, again, and can I ask you again, your experience, do you see do patients, and I know you don't have a lot of patients on these medications, but do you see patients come back to you and tell you they're drinking less as well? On semaglutide. I'm going to project here. I think long term, and I'm not, I'm not an advocate of this now, but I think long term, the GLP-1s are going to find their way into the armamentarium of the treatment of alcohol use disorder, just because the early data is suggesting
Yeah,
that.
yeah, we have data on that too, and I think that is, I think like what you're saying is like, and I think what this comes back to it because back then when we started the podcast, I had two or three doctors say I should lose my medical license for saying that food has anything to do with addiction. I was like, the data is going to clear. We know what we're seeing. We know
Yeah,
what we're seeing. We may be wrong on the mechanism. We're not. We're just saying we're making this observation where people are like when they get their lifestyle right, they don't need alcohol as much. It's just like you think about it. Jason Fung and I were talking about this because we were talking about how we use food for to bring comfort and peace and stuff. No one knows anyone who said, hey, I'm in the middle of a massage. Like you get an hour long massage, 30 minutes and go, okay, stop the massage. I'm going to go eat something. I'm hungry. I got to eat something. No one's on a hike out in the middle of the desert and it's a beautiful day going, you know what? Let's go back. I need to eat something. Like
Yeah.
we can overcome those things, but if we're in a peaceful state, we do better. If you're stressed and tense and hate the world, that this is what I'm getting at. I've seen it in my practice, and that's why I changed it to metabolic health, because you cannot just go on a ketogenic diet and think you're gonna like light the world on fire lifestyle without exercising, without watching your stress, without getting sleep. All these things play a role. So my patient, I'll sit there and go, okay, you're a stressed out, middle-aged real estate agent with 3 kids. You don't have time to talk to me on the like we're in a Zoom meeting and you're like, hold on, doctor, I gotta answer this email. I'll be right with you. Like, that's how their life is all the time. It's like you're not gonna have success. You're gonna struggle. You got to fix something.
Yeah.
Boundaries,
Yeah.
relax, take a breath, all these things. And you and I were smart enough. Like I know what you did in the ER, stressful, right? But the funny thing is when I do a lot of medical trips, one of my best friends, and just as an aside from talking about the ER visits, I asked my buddy, he was just here for his physical, and I said, hey, what do you see the most? And he's in South, South San Diego near the border. And he goes, it's either fentanyl overdose, depends on the day. What he's seeing the most right now, fentanyl overdose or hyperemesis from chronic marijuana use. He goes, those 2 things we see the most. I said, of anything, heart attacks, strokes, car accidents? He goes, yeah, by far. Not even close. And I go, come on. So I put a thing out on Twitter and I go, is anyone else seeing this? And tons of ER docs like, yep, that's what we're seeing too. I was like, holy cow. So it just shows you the addiction that we're going through right now and the mental health and the depression and the anxiety. Um, so anyways, getting back, the funny thing is we get back from Cuba and we had no internet connection. I opened my laptop and I had like 3,000 messages on there. And he's like, holy cow. And he goes, I didn't want to show you. I have none. He had no emails or anything because you leave and you're done. So it's that acute stress. You're there. It's like you're the Navy SEALs. You're there stressed out for 12 hours or whatever your shift is. And then you're 4 days off and you get to go and relax with your family and do what you want to do and like recuperate. But us
Yeah.
primary care docs are like, we're the infantry that's there for 10 years straight without catching up, without
Well,
taking a break, right? It's
you've
not
got
good.
that longitudinal relationship with your patients, which I do now. And I mean, I'm sure you're the same way, Brian, is that you have somebody that's struggling and you can't stop thinking about what you're going to do next to try and help them. So, um, and I got to interject one other thing here, which is, you talked about, mentally being in this good place that decreases these stresses and that decreases this need to pursue addictive behavior. And I know for you, the spiritual component and the faith component is so critical in that regard. And my assumption is in your practice for the appropriate patients that want to hear it, you share that with them as possibly a mechanism to help them get where they need to be. Is that true?
Absolutely. And for me, I mean, people who know me, my friends will say, look, I don't force my faith on anyone. That's why I started this podcast, as a matter of fact, because the
Yeah.
atheists were attacking me all the time for talking about hope and faith during the lockdowns. I go, it's going to get better. And guess what? I was right. They said we'll never get better. It's a lot better than it was a year and a half ago if you look at it, right? I was just
Yeah.
thinking that yesterday. I went to the gym. I'm like, how happy am I to go to the gym? I don't have to wear a mask. I can smile at people. I can wave to people. I, interact with people. We need that. That is part of this whole human experience. If you don't have that, you're in trouble. Like you isolate us and we're a disaster on our own. You put me on an island by myself and I'm a total disaster. So, that's part of it. I'm sorry. I got so distracted by, what was your question again? I
So
get
it's
so
just
excited. Oh,
yeah,
faith. Okay.
integrating it, the need really to decrease the stress and anxiety and the value of faith, and I'll
Whether
use that.
people like it or not, whether
Yeah.
people like it or not, here's the deal. I don't talk to my patients about, I don't like go out of my way, but they know, they see my pictures of mission trips that I've done. They say they know my stand. They know where I'm standing on the podcast. They know. So I select for people who are of faith. And I don't select, I mean, they select me. I'm not selecting them. I'll take anyone. I don't care what your faith is. And I respect all faiths. And I go, hey, you look, if you're Buddhist, you want me to pray with you? Let's do it, man. Right? Like if you'll
Yeah.
take that. So what happens is a lot of times my patient will go, I've had a horrific week and everything's terrible. And like, how you doing? And they say, Doc, can you pray with me? Yeah, I can't. That's just another tool I have, just like you're gonna have naltrexone. I have that in my quiver that I can pull out and go, let's pray. And if I could pray with you and calm your stress level, I'm telling you, people don't realize it. And I saw it on my own, and people can see it on their own CGM. If someone prays for you or touches you or connects with you, your sugars go down. I have people that get massaged and their sugars come down during a massage because they're going to parasympathetic mode, right? When you go, the whole weight of the world isn't, someone understands what I'm saying. These kind of things, these human connections that we've lost in medicine, forget it. You're not going to be these big programs and be able to pray with people. But I
Right.
have times when for instance, I went to, when my buddy has like go-karts at his house. He works with kids that are in the inner cities, and he brings them out, lets them ride golf carts on his uh, land. Basically, he has a big ranch, and they go out there and have a blast. Yeah, and so, anyways, I was doing that, and you get your adrenaline up. So my sugars were really high after that. And then I went to church, and my buddy prayed for him. He goes, "Brian, how's things? Let me pray for you." And he prays for me. And I went back and I looked at my sugar tracings. It dropped from 158 when I walked into the church to like 70, right?
Yeah.
Just being at peace and not thinking about stuff and being so shutting the brain down, whatever it is, whatever. If your faith is collecting rocks, do that. If you like, fishing, go fish, go do stuff you enjoy. Like, give me a break, right? Enjoy your life a little
Yeah.
bit.
Yeah. I mean, yeah. I mean, I think a higher power needs to be involved in some way. My background is traditionally Catholic. You saw the Notre Dame thing. I, have actually about 18 years of Catholic education. And I fell away from involvement for a period of time, just raising kids, busy. And it's been very refreshing to reestablish my active Catholicism and my faith in recent years. And actually I got to thank my wife primarily for that because she's the one that's kind of been steadfast through that whole period of time. But there's no question that people that have some kind of faith, preferably with a higher power, can get to a point of managing that stress and anxiety better.
Yeah, and I think that's an important point. And that's the other thing. It's so important that so many people have this perception that, okay, you're a doctor, you should know better than this faith hocus pocus crazy stuff that you guys believe. And it's amazing because the more you're around, especially you being an ER doc, I know you've lost patients that you're like, what the heck happened? How did they die? They shouldn't have died. And other people that come through this horrific thing, you're like, how did they survive that? They shouldn't have survived that. I have people that survive stuff that you go, how on earth could you have possibly? And that's what I did in this podcast. I brought people. I go, hear Tom's story, hear this guy's story, hear these people's stories. And when you hear it, you go,
Yeah.
the odds of these things, like you and I crossing paths. What's the odds of all these things? Some guy in Ohio, some guy in California, we cross paths, and you say, okay, what do I get from that? Like, how, uh, where people have knowledge, we don't check our intellect at the door, right? But then you see things and you go, I can't explain this. Okay, there's something more than I can explain in scientific terms.
Good or bad. I don't know what you've experienced. I'll share something a little personal. So I like I'm still working some emergency department shifts at the VA in Dayton. And I don't know what it is about the veteran path population, toxic exposures or whatever, but it just like in the emergency department, which you wouldn't think the primary diagnosis of a malignancy would that the first place you would find it is in the emergency department. Usually it's a pattern of disease process over a period of time. But I just see so many patients that I mean, healthy people, they come in and it's like, oh, you got some abdominal pain. We did a CAT scan. Oh, looks like you have metastatic pancreatic cancer. Or, you're having weak and dizziness and a little bit of a cough. Oh, we went ahead and worked you up and you have a lung cancer with brain metastases. And for me, I feel you know, more and more like I'm much, I don't, than when I was younger, and when I was less faith based. I I have such a closer connection and emotional involvement with these patients, even though it's just an emergency department visit. And it's like, I pull up the computer and I look at the CAT scan, and this is a man that's in there with his wife. He's just had abdominal pain that hasn't gone away for 6 weeks. They're just here to look into this and get it taken care of. And I got to gather myself, even very emotionally sometimes, and I'm more emotional now than when I was younger. I don't know why, but how am I going to handle this? Walking back into the room and talking to them about this with relaying objective information, but not painting a hopeless picture. And having a faith background, and sometimes when those patients express that in those situations, I think can add so much more to their experience and their dealing with that, and quite honestly, add so much more to my experience taking care of them.
Yeah, I think that's it. I think as we get older, you get more compassion, you get more, you start realizing, okay, I'm not that, how old are you? You're 60, whatever. You're talking to the patient, you go, I'm only like 8 years behind you, right? So you start realizing our mortality. And I think in medicine, especially emergency medicine, I respect you guys a lot because you're seeing people at their worst and their most stressed. And not only that, you're trying to take care of this guy. You could diagnose a metastatic cancer in someone who's there for stomach pain, and you're going to rock their world like crazy. And then you
It's
have,
it's a
you know,
life-changing moment.
and
Am
you
I
have 10
getting
other
older?
patients to see,
Yeah,
right? And you go, I
yeah.
got to be mindful of my time. I got to be diligent. But I can't tell you how many patients go into the ER and they go, you have cancer. Okay. In 2 months, you can see the specialist will refer you, whatever, because it's so devastating. And I think what you're saying, and this is why I wanted to do this podcast. So I'm glad you brought up is it's about hope and faith because even if you get a horrific diagnosis, I've had times like crazy stuff in some of my trips I've been on where I got a machine gun pointed at me and they're like shaking me down or whatever. It's like, okay, if this is my time, it is. I'm good. I'm not ready to go, but if it is, okay. So having that kind of thing is the worst thing, and you've seen it too, and I know I've seen it too many times, where someone has metastatic lung cancer, right? They have a horrific prognosis, and they're so fearful of dying that they're like, I don't care, do everything, put me on a ventilator, put me on a feeding tube, do all this stuff, and then you're still going to get to that point of dying, but it's going to be 2 months of horrific torture, right? Or
Right.
whatever it is. And you look at
Yeah.
it as like if you're at peace, and I'll tell you, Paul, this is one that really impacted me. I was having a horrific night in the ICU. I was the guy in charge of the ICU that night, and I was so busy. Like people were bleeding. It was like horrific. Like me and my partner were like, this is the most like what's going to happen next? And I get a call from I finally get a down minute. The surgical intensive care unit cross all calls me. He goes, Brian, can you come talk to this guy? He's refusing oxygen. He's refusing everything. He's being non-compliant. And he was like, and I go, yeah. I was annoyed. I'm like, okay, I'm gonna run over and just tell this guy, like, look, I don't have time for this. Get it. So I sit down with the guy. I go, so what's going on? And then we start talking. He goes, son, look, I've lived a good life. My wife died 2 years ago. I have, horrific COPD. And he's telling me how many times he's been in the hospital, all he's been through. He goes, can you just let an old man make a decision and not put the oxygen on and just let me go? Like, let me just relax, and not, what's my outcome? You're gonna like keep me on oxygen tonight. Then what happens tomorrow? He goes, I met with my family. We prayed together. I'm at peace. I'm ready to go to the Lord. I'm struggling every day. I don't have the quality of life. Can you let an old man just not wear oxygen for a night? And I said, hey, you know what? He goes, can you pray with me? I prayed with him. Right.
Yeah.
And he died that morning. Right. I
Yeah.
went back and took care of all the stuff I had to. This guy went out the way he wanted to without, being struggles. Like, I'm not going to judge anyone like that. What do you like? Sooner or later, it's going to be you and me sitting there and we're going to make a decision. We want people to respect what we want.
Absolutely. Isn't it amazing, Brian? I mean, you can go back 20, 25, 30 years, and you have those specific poignant memories of those specific patient interactions. And usually that's with satisfaction that you handled it correctly and you did for those people what you could do. But that's an example for me. That's why, you hear from some docs these days about, I don't think I'd want my kids to go into medicine. Medicine has changed. We've talked about the problems here today with the health systems and the job that docs are relegated to. I'll tell you, I'm still, after over 30 years, I still enjoy what I'm doing, and I'm still grateful to be in this profession because where else can you touch people's lives like that? And so I think medicine is a great profession, and I think you got to figure out where your niche is and how you can approach this. And I think you and I have both, searched for that and found that. But I think medicine is still, I would still encourage anybody to go into medicine if they have an aptitude for it and they have a passion for it.
Yeah, and I think if you're chasing the dollar and you think I'm going to make a lot of money, I'm going to be secure, all those things, you start looking at it like you and I, and just in talking to you, it's interesting. You look in when we applied for med school, you have to do a personal statement, and I was like, and 10 years, 15 years into my career, I'm like, am I living that out? what I said I came to medicine for. Because when you realize you're a cog in the wheel and you're working 18-hour days and you start resenting people for coming in, you're like, oh my gosh, another patient. I don't want to deal with someone else. I don't want to admit someone else at 2 in the morning. When you start getting that attitude, it's like, okay, why did I go to medicine? I think you're right. I absolutely 100% I would do it again, doing what I'm doing now. But if you sentence me to what I was doing 3 or 5 years ago, I would say, you know what? It's just not worth it. I mean, the personal, like people don't realize the personal sacrifice we go through, the amount of holidays, like the ER doesn't close on Christmas Day, it doesn't close on
Yeah.
your wife's birthday, it doesn't close on all these things. And sometimes you're stuck and you're like, oh shoot, I'm gonna miss the wedding because I gotta be on call that night. Whatever it is. Sometimes it's such a huge sacrifice. And right now, doctors are some of the least popular people based on the last 30 years. A lot of people are not happy. They're suffering and they're going through stuff that their doctor forced onto them or recommended to them that caused issues. And so it's a hard thing. And right now, we're the number two suicide in the country. We got number one is people with PTSD from the military. Number two is doctors because we're struggling with all these things.
Yeah, yeah, I agree, but I agree there are challenges. It's hard, but if you have a passion for it, and sometimes you have to balance those issues. Like I know both you and Tro did, me to some extent. It's like, okay, I'm going to pivot here in terms of what I'm doing professionally, and I'm going to have to work harder for a period of time with this new practice, or I'm going to take a financial hit for a while with this new practice, maybe long term. But it's still worth it.
Yeah, it's,
So
it's not long term is because if you provide that service and you provide good care, people will find you and they'll go, look, I want you. I don't want to deal with someone who doesn't. Yeah, I mean, it's insane. I have doctors flying down. I have two doctors that fly down from Oregon to see me. I'm like, what the heck are you flying down here to see me for? Like, they establish care with me. Like, they go, I'll come down twice a year. I'll do what I have to. Let's do Zoom meetings. I'm like, why? They say, I don't trust any doctor in my practice. In my hospital, I don't trust anyone. Based on what I've
yeah,
seen over the last 2 years, I'm like, I don't trust anyone, but I
yeah,
trust you. I know what you're saying, and I'll put my life in your hands, right? And that's the payback, right? For saying,
yeah.
okay, look, I hopefully you see that. There's other people who won't like us, but there's things where you just have to realize if we're all humans and we have to connect on that level. And that's why having your faith, having things you can lean on when we're all going to have bad days. For me, it's like, okay, let me pray. This next patient's a jerk every time he comes out. I don't see that anymore, but it used to be. But being able to say, okay, it's not all the responsibility on my shoulders. Like what happens? Sometimes things happen that we just can't explain. And you go, okay, God, like I need you in this situation and be able to do that. I had to really, I'll tell you, if my faith was in science and the medical establishment, I would lose my mind. But my faith is not in that, right? I know no matter how bad things get and how corrupt things look, it all works out in the end. So you go, okay, I can go through the valley to get to the peak again.
Yeah, absolutely, absolutely. And actually, you mentioned some docs coming to see you. The ultimate compliment. Yeah, I've had a dozen docs be my patients, and and that goes back to the thing we were talking about with the metabolic health movement moving forward. These are docs that grew up in traditional medicine, and it hasn't worked for them individually.
And they know it
Uh,
doesn't work. And that's what I had to come to that conclusion. It wasn't working for me. I was going to get diabetes. I was going to have health problems. I'm like, I know what comes with this. I don't want it. I'll do whatever it takes. So when you get that mindset, instead of saying I want the magic pill or the magic shot or the magic surgery, you go, okay, look, I'm taking this on. I'm gonna face this, just like what Tro did. He's faced it, and so a lot of us have done that. And I think and for me, it was really self-preservation because I go, look, I love this part of it. I love, like you're saying, there's no greater reward than sitting with the patient and saying, hey, look, we can fix this problem. You're on insulin, no problem. We can work on this together. We can do it. I can't do it by myself, and you can't do it, but together we can. So when you start saying that's what we went to medicine. So for you, preventing these horrific things that are coming and the patient never even knows it. They were driving towards a cliff and you turned their car so it's not going towards the cliff anymore. And they're
yeah,
going to be able to play with their grandkids and great grandkids. And that's what we went to the medicine for.
yeah,
And I think, and especially if you have faith and you could use that tool when you need to. If you don't need to use it, then you don't, right? And so,
yeah.
yeah, I think it's so amazing the transformation that you went through too. And again, taking a pay cut and doing what I know my taxes, I pay less taxes than I did before because I'm not making as much money as I did before. But it's coming. We build our practices. It takes time, word of mouth, and you do the right thing and it builds up. And so it's really just being patient with the process and saying, hey, look, we're practicing good medicine.
Yeah, yeah. And I'll tell you, maybe just being a little bit older. offers perspective here as well. As you get a little bit older and you realize your mortality, I don't know, that helps my faith. I realize that I can be at peace a little bit more, understanding the human condition, and that physiologically we all are going to have finite limitations. And I think it helps me relate to patients better as well, because I can empathize a little bit better. I know their situation with patients that are sick, because sooner or later I'm going to be sick too, and the older you get, the more likelihood of that happening.
Yeah, and the life pressures, and I think the other thing is that as we get older, the benefit of for is life experience. We've dealt with a lot of stuff, we've seen a lot of stuff, and we've been through a lot of stuff. So when I see a young mom and she's got 3 kids and she goes, "I'm exhausted all the time, I'm tired," I'm like, "Yeah, trust me, we were there. We know what it's like when you're not sleeping at all. You're waking up 8 times a night, and
Yeah,
frazzled, and the sex drive drops and all these things. Like, this is normal what you're going through. Here's what we're gonna do, and you start helping people a little bit and throwing them a little bone. And like what you're saying is like, can we tweak this a little bit? If we need to use a drug for a little while, let's do that. We're not anti-drug. I mean, we went through medical school. We understand there's benefits to some things. And sometimes you say, well, let's temporarily do this and we'll wean you off and we'll get you squared away. And so I like your approach of saying, hey, look, it's the human. Like, what works for you? If I tell you, okay, you're just gonna eat liver the rest of your life, you're like, okay, I'll just die a little bit earlier. I'm not gonna eat liver every day. At least I would say that. And so, anyways, you start looking and saying, what works for that person in front of me? How can we help them a little bit here and there? And then once they start grabbing on, people start doing great, and they start feeling better. You see the life in their eyes again, instead of being like exhausted and miserable. So yeah, you're right. I agree. I mean, there's no greater calling than to be a physician, but you have to use your skills in a way that works for you and the patient. It has to be a thing where if you're stressed and tense all day and you got all these patients, you got all these charts you got to work on until 2 in the morning and all this stuff, that doesn't make you a better doctor or a better husband, better father, whatever. It's those things. We have to look at the balance in life. And I think a lot of doctors are so out of balance, and then they're nasty and mean and attack people on Twitter because they're in a grumpy mood all the time. I mean, that's just it comes out like what is in your soul comes out a lot of times.
absolutely.
So, Doc, what's life's
Hey,
best medicine for you? I know you were on episode 126. We figured that out. So, and then also, I want to hear about what life's best medicine is for you right now, and see if that changed from last time. And also, let people know how to track you down. If you want a good doctor in the Midwest, here you go. And
yeah,
also, how people can get your book too.
yeah. Life's best medicine for me is just, basically my family, my faith, and being able to take care of my patients. I mean, well, it can't get much better than that. I mean, I don't have a lot of, I mean, yeah, I can create stresses. We all can create stresses, but I'm happy where I am right now, and I think again because of faith, profession, and of course we haven't talked a lot about family, but I'm just fortunate. I'm going on what my wife would question me. I'm going on my 43rd year of being married.
Wow.
So, I was fortunate that my wife picked me. Yeah, and
Welcome to the club, man. Yeah, no doubt.
yeah, I'm just fortunate, and I'm blessed every day.
Oh, that's
Um,
awesome, man. That's kind of and before we jump on that onto the rest of this, just curious, what happened to what did your wife say when you go, hey, I'm thinking about focus on metabolic health stuff, and I'm leaving the ER for the most part.
she's great. So actually, I don't know if you know this, Brian, but she's an emergency physician as well.
Oh, yeah, so she
Okay.
gets it. Oh
And,
my goodness.
and when people meet us, it's clear she's like an amazing clinician. And though I the last 10 years have been doing some of the addiction medicine stuff and the metabolic health stuff, she continues to just because she enjoys it and because she's so good at it, not working, still not working 20 shifts a month now, but still working 10 or 12. She's just a great clinician and she enjoys going to the emergency department. And quite honestly, she has allowed me to do some of these other things with her approach to enjoying her profession and her support of me. So it's I'm blessed. We kind of understand each other. I mean, just marriage is hard, I mean, that's I don't need to highlight that too much, but marriage is, you got to be committed, and there are periods of struggle, and there are periods where you don't see eye to eye, that you figure out a way to work through those, and we have figured out how to do that over the period of years, and probably like you, I feel blessed to have the spouse I have, and I feel blessed to have the best friend I have.
Yeah, that's amazing. I'm the same, man. I got it pretty dang good. When people say marriage is hard, I'm like, man, I got it. Yeah, my wife might agree with you, but I think, man, I've had it pretty good. I've got a great wife, but she's not in medicine too. Being in medicine, two people in medicine,
Yeah,
strong-willed, and that's a challenge. It is, for
yeah.
sure. It makes life a bit challenging when you're both beat up and exhausted and running around and dealing with horrific stuff and stressful things, but you get those benefits of helping people and holding their hand and being there for them emotionally when they're going through the worst day of their life, maybe for some people. So, how do people track you down, Doc?
Okay, so the name of my practice is Metabolic MDs. So we both got that metabolic in our name now. So
Yeah,
it's the word metabolic MDS.com. And I'm licensed in Ohio, Indiana, Florida, and Arizona, doing the majority of work by telemedicine now, though have an office in both Ohio and Indiana. The book is on Amazon, The Continuous Glucose Monitor Revolution for Non-Diabetics. And then I am on Twitter as Dr. Colo, and on TikTok. That I've got that's for some reason I do best on TikTok. I don't know. And that's at dr.kolo. And then I'm also on, you can find me on LinkedIn and YouTube, etc. So
awesome, Doc. And your book is available on Amazon.
available. Yeah, just go to Amazon and put Kolodzik in, or the continuous glucose monitor revolution. And it's meant to be kind of a Bible, maybe for people that don't necessarily have a doc like you or I. But we're working with the primary care doc, and the primary care doc is willing to prescribe a CGM. It's kind of a Bible, chapter by chapter, of all the things we've talked about. Why is low carb a good approach as opposed to calories in, calories out? Why does intermittent fasting work? Why is strength training important? If you want to dip your toe into this semaglutide thing, there's a chapter on that, and then the global view of why CGMs are so valuable.
Awesome, Doc. Hey, and thanks for sharing your faith. Thanks for coming on. I think it's so important for people to hear that. It's an encouragement to people, and just for other doctors out there, look, so reassess where you're at. It takes, I don't use the wrong term, but it takes some courage to step out of the system. But if you can be more effective and help more people, there's this whole idea that, well, if you go into like direct primary care or somewhere you see fewer patients, you're hurting the system. Well, I think you're hurting the system if you're spending 8 minutes with a patient every day, and that you can't be invested and you don't know your own patients and you don't have time to deal with it, and you can't see your kids and your wife and or husband. And there's costs and benefits and everything. And I think as doctors, we are trained at looking at risk and benefit. And that's what I had to assess in my life. What's the risk? What's the benefit? The benefit has far outweighed the risk that I took, right? So you start looking at that and you go, okay, I can go home and relax a little bit. And I don't have to be stressed and tense and, answer to the man every day. There are benefits. And the reality is this, and this is what happened with me. I stepped out of the machine and some other cog jumps in and takes over, and boom, life just goes on, right? But your
Right.
life gets better. So, Doc, thanks so much for joining me. Everyone, be kind to yourself, be kind to others. Thanks for listening, and thanks for giving us an hour and plus of your life to listen. Doc, any last words for my people?
No, other than I want to thank you, Brian. You've been gracious with your time, having me on here, having me back. I'm really appreciative of that. It's great talking with you.
Yeah, and it's great to have docs who are changing the system and helping their patients. And we're not going to change everyone, but we're going to help the people we can, and that's all we can do.
All right. Thanks a lot.
Thank you. Thank you for listening to this episode. We greatly appreciate your support. We would greatly appreciate a positive thumbs up on all of the platforms like iTunes and Spotify or wherever you're listening. And we just thank you for our Patreon supporters. We greatly appreciate your help in getting this message out. We think there's a lot of important information, and hopefully this helps you. Have a great day, and thank you for listening, and thank you for your support.